In this module, we would like to present some observations from the Aortic Institute at Yale University regarding the natural history of type B dissection and clinical implications of those natural history observations. We will present 10 specific tips that can be gleaned from our database. One has to do with the aortic dissection as the great masquerader. We will look at the important role of exertion and emotion as inciting events for aortic dissection. We will examine the characteristic that type B dissection is, by comparison to type A, a relatively benign process. We will look at the fact that dilatation, when it does occur after type B dissection, affects predominantly the upper descending aorta. We will look at the question of whether type A dissections are frequent or not in the long-term follow-up after an initial type B dissection. We'll look at several specific characteristics of type B dissections in Marfan's patients. We'll comment briefly on the pathologic variants of dissection, IMH and PAU, or intramural hematoma and penetrating aortic ulcer. We'll offer some observations on indications and timing for surgical intervention. We'll look at the role of the fenestration procedure in malperfusion events. And we'll look at the importance of false lumen thrombosis that Dr. Tremarchi and colleagues have identified. First, aortic dissection is the great masquerader. Because aortic dissection can affect any of the branches of the aorta from the coronaries to the iliacs, it can masquerade as a primary disease process of the organs served by any of those branch vessels. So it can look like a heart attack or a stroke or a spinal cord event or an abdominal event. For type B dissection, it's especially important to keep in mind that that can present as an abdominal catastrophe from ischemia of the kidneys or intestines. This disease really is the great masquerader, and it requires a high index of suspicion and a recognition of this possibility of masquerade as a primary abdominal phenomenon. Our studies have shown that dissection does not occur randomly, but rather it has particular precipitating events. We have found that in over 2/3 of our patients, we find that the patient and or the family remember a particular physical stress event or an especially stressful emotional event immediately preceding the onset of dissection pain. So we don't feel that these dissections occur at random, but rather that they are precipitated by acute hypertension. You may be aware that we have found that the very important activity of weightlifting, which we support and fully endorse for maintenance of muscle mass, especially as we age, weightlifting can be associated with precipitation of aortic dissection in healthy athletes with the predisposing factor of an enlarged aorta. And we see here the dramatic elevations in blood pressure that can be seen with the weightlifting activity. And we have reported on this on multiple occasions. This particular report here examines in detail 31 particular cases that we received from around the country in which the dissection was precipitated by weightlifting. So we feel that the genetic predisposition to aneurysm disease is inborn. There's a complex pathophysiology involving the MMPs that leads to destruction of the aortic wall and aortic dilatation, but then it's often a particular exertion or emotion that causes the acute severe rise in blood pressure, which precipitates the splitting of layers of the abdominal wall. It's interesting to point out that one of those patients in our report of the 31 from around the country was a cardiac surgeon who was doing the bench press and knew immediately that he had suffered a type B aortic dissection when it occurred. Now, in terms of the risk of complications, the descending aorta does not suffer complications until a little bit later in size than the ascending aorta. Here you can see that it's between 5 and 6, and ultimately with a strong hinge point at 7 centimeters, that the descending aorta ruptures or dissects. So intervention somewhere between 5 and 6 centimeters is highly recommended. Now, in contradistinction to type A aortic dissection, we feel that type B dissection is a relatively benign process. We've looked at this on multiple occasions, and we examined 100 consecutive patients with acute type B aortic dissection that we treated. Please note that 91 of them survived. That's a pretty high number. 9 died, and of those 9 deaths, only 6 were directly aortic related. Among the 91 survivors, 60 had a completely uncomplicated course. They came in, they were given beta blockers and afterload reducers, and after 6 to 7 days they went home, and it was a purely medically treated phenomenon. 31 of them did have various complications, some of which required surgical interventions of a kind that we'll examine later in this module. Now, an important point is that as much as we love to operate on type A dissections, and as good as the results are there, it's a different phenomenon with type B dissections. The vast majority of reports have found that operating to replace the descending aorta in acute type B aortic dissection is fraught with problems, especially bleeding. Dr. Greep and colleagues have produced the only report of which we are aware with excellent results after this operation. Most centers have found a very high rate of anastomotic bleeding. That may be related to the fact that the number of lamellae is much lower in the descending aorta, more on the order of 28 to 30 compared to the 65 to 75 in the ascending aorta. So the dissected tissue that we have to work with is much less substantial in the descending aorta than it is in the ascending. Now, in our experience, in long-term follow-up, over 10 to 15 years, the dissected descending aorta does tend to dilate, and the dilatation tends to be predominantly limited to the proximal third of the descending aorta from the subclavian on down. As we can see here, the descending aorta grows a bit faster than the ascending and even the thoracoabdominal aorta. We asked ourselves whether type A dissection is common after type B dissection. We really didn't know, so our team examined this, and they looked at 118 patients who had suffered acute type B dissection and examined how many of them suffered a type A dissection in long-term follow-up. As you can see here, we were very surprised to find that this was a very small number. Only 2 of those 118 patients suffered a subsequent type A aortic dissection. This is much less common than I would have predicted or anticipated. So type A dissection is not a frequent natural history event following type B aortic dissection. It's worth looking at type B dissections specifically in Marfan's patients. In Marfan's patients, it has been found that the predictors of a dissection occurring, and about 16 to 20% of Marfan dissections are type B, the predictors are a previous aortic root replacement, a large diameter of the descending aorta, severe hypertension, the presence of aortic regurgitation, and the presence of highly abnormal aortic compliance. In our own experience here, we found that a good number of our type B dissections in Marfan's patients occurred after prior ascending aortic replacement, and a good number of patients with type B dissection and Marfan disease went on to require direct aortic surgery. Now, these pathologic variants of aortic dissection, IMH and PAU, have garnered a lot of attention clinically and in the literature. You see them depicted here. The critical differentiating factor is that dissection has a flap that goes obliquely across the aortic lumen. The penetrating ulcers look just like duodenal ulcers, but they're in the aorta. And the intramural hematomas, rather than having a flap going across the aorta, only have a crescentic shadow of blood within the aortic wall rather than a flap. The ulcers usually occur in advanced age, 80, 85 and above. The asymptomatic ones we usually just follow unless they have a very malignant appearance. The symptomatic ones we usually operate or, in this era, treat by stent therapy. For intramural hematoma, I use the rule of 1/3, and that is to say that 1/3 of intramural hematomas stay the same. 1/3 go on to become typical aortic dissections, and 1/3 heal entirely. That's an approximation of what we found with midterm follow-up of these entities in the range of 3 to 5 years. In 1992, we reviewed the literature on recommended treatment for type B aortic dissection. In those early years, there were centers that advocated routine surgical therapy, and there were centers that felt that routine surgical therapy was fraught with complications, and these dissections should not be operated on. In reviewing our results, we came to the conclusion that the truth probably lay somewhere in between, and we articulated what we called the complication-specific approach to type B dissection. This approach recognized that many type B dissections are completely uncomplicated, as we saw earlier, and we felt that they required nothing more than medical management. And then we examined the particular complications. For rupture, of course, we always recommended graft replacement, which currently can be done either by open surgery or endovascular approaches. For rapid expansion, indicating impending rupture, we also recommended graft replacement, which these days can be done either surgically or by an endovascular approach. However, for organ ischemia, we found through a relatively large experience that the fenestration procedure worked very, very well. And we'll examine that technique in the slides to come. In this era, fenestration can be done in the cath lab by interventional means. It can also be accomplished in about 90 minutes in the operating room before the cath lab team even has a chance to get to the hospital. For the uncomplicated patients, the anti-impulse therapy is important. The solid curve B here represents the normal untreated arterial wave form. It's important to recognize that, as in A, if one gives only afterload reducing drugs, one actually increases the DPDT. The DPDT is the slope of the initial upstroke of the blood pressure wave, and that is deleterious. As we see in C, the administration of beta blockade can blunt that DPDT by decreasing the slope of the initial upstroke of the arterial wave form. So by combining afterload reducing drugs with beta blockers, one gets a reduction in the strength of cardiac contraction in the DPDT and also a reduction in blood pressure. And that's what constitutes modern day anti-impulse therapy. The complication-specific approach has been followed widely, and it is also presented in this interdisciplinary consensus document, where medical management is recommended for uncomplicated type B dissections, and intervention is recommended for instability or other complications. This document did recommend medical treatment for uncomplicated type B aortic dissection. It recommended intervention of one sort or another for the complications that you see listed here. And TEVAR was recommended as the first-line treatment for complicated acute type B dissection, with open surgery being an alternative option. In terms of the treatment of chronic type B dissection, these aortas are really treated like other aneurysmal aortas, with intervention for increase in size or rapid enlargement. Let's look now at the fenestration procedure. We've written about this on multiple occasions. The whole principle is to decompress the false lumen and in that way take away the narrowing of branch vessels that produces malperfusion. This is a very quick procedure. Please keep in mind that this procedure does not involve any prosthetic grafts. It's done at a low abdominal level, so there's no need for any left atrial femoral bypass or other perfusion adjuncts. It uses all native tissue. And our experience shows that it's very, very, very effective at eliminating the malperfusion, both above the level of the surgical fenestration and below the level. That is, both to the abdominal viscera and also to the extremities. We make an oblique incision in the retroperitoneal zone as seen here. We divide the obliques in line with their fibers. We currently use the Omni retractor, which really facilitates this procedure tremendously. We expose the infrarenal abdominal aorta. We transect the infrarenal abdominal aorta. You see here the flap at that level. We excise the flap from the upper aorta up to the level of our clamp, as far as we can reach to get a maximum decompression of the false lumen. We then reconstitute the aortic wall distally with a simple running Prolene suture. We sew the two layers together. This always holds. We don't have to use pledgets here, and hemostasis is simply not a problem. We, as thoracic aortic surgeons, are used to bigger aortas with a higher wall tension. The aorta is so small down here that it holds easily without complication. We then sew the fenestrated upper aortic limb to the reconstituted lower aortic limb with a simple running suture, and the fenestration is accomplished. The false lumen decompressed and malperfusion corrected in over 90% of cases. There are some misconceptions about fenestration. It's important that it be done early in order to be effective before there is thrombosis or fibrosis in the false lumen. We recommend that fenestration be done within 48 or at most 72 hours of the acute event. As I've mentioned, it's very effective at restoring perfusion both above and below the level of the fenestration. It is quick, well tolerated, and life-saving, and requires no bypass, no pump. It really has a minimal risk of paraplegia, and there's no foreign material. Finally, it's worth looking at the important findings of Dr. Tremarchi and colleagues, who have zeroed in on the status of the false lumen in aortic dissection, and they have found that partial thrombosis is bad. Either a wide open false lumen or a totally occluded false lumen is better. As you can see here in univariate and multivariate analysis, the rate of expansion of the aorta is higher when there is only partial thrombosis of the false lumen. So those patients require more vigilant observation. To conclude, type B dissection is, by comparison to type A, a relatively benign process. When patients survive the acute episode, they usually are bulletproof for years and years. They will ultimately develop enlargement of the aorta, which is usually limited to the proximal third up by the subclavian. Fenestration is very effective for malperfusion. You can do it surgically as seen here, or it can be done by fenestration in the cath lab. For rupture and threatened rupture, acute graft replacement has to be done in some way. Surgery traditionally has not been favored, and endovascular options are currently available to us. The routine application of endovascular options to improve the long-term outlook of type B dissection patients is currently being investigated. Thank you.